Good afternoon, and thanks for joining us for the second webinar in our Data to Care Community of Practice series. My name is Erin Bascom, and I'm an associate with the prevention team here at the National Alliance of State and Territorial AIDS Directors. We are excited to have a number of presenters joining us today. So after a brief introduction from our partners at DARE Global Innovations, we will have a presentation from Colorado. So we have on the call today Rebecca Jordan-Yale, the Client-Based Prevention Program Manager from Colorado, along with Maria Chidas, the State Linkage to Care Coordinator, Kelly Voorhees, the Surveillance Data Integration Unit Supervisor, and Anita Watkins, the Surveillance Program Manager. And the Colorado team will be sharing their data to care process, protocol, and tools. Following Colorado's presentation, we will also have brief case studies from Louisiana and from New York State. Debbie Wendell from Louisiana will discuss the LA Links Data to Care project, and Megan Johnson, the Prevention Services Coordinator from New York State, will share their expanded Partner Services Program protocols. We also have Michelle Wozniak from the Hawaii State Department of Health, who's going to be our Community of Practice facilitator today, so she will also be jumping in with discussion questions and polling questions throughout the webinar. So now I will turn it over to Tiffany West at DARE to get us started.
Thank you, Erin. Welcome, guests. We appreciate you taking time out of your busy schedule to participate in our ongoing community of practice related to the Data to Care initiative. CDC instituted recommendations for Data to Care, which is a new public health strategy aimed at using HIV surveillance data to identify people who are not in care, link them to care, and support the care continuum. There's a toolkit that was developed in collaboration with some of our presenters, CDC and John Snow Institute, located at the Effective Intervention website. These resources include a list of important considerations, other health department case studies, and tools and resources. We advise implementers or people considering implementation to please visit the website and look at the tools. The goal of the community of practice for Data to Care is really to strengthen our public health workforce and learn from members, share experiences, and work together to solve common problems. This pilot is a series of interactive conversations between jurisdictions on strategies, challenges, best practices, and opportunities for implementation of Data to Care nationally. We hope after the series that we'll have a comprehensive list of best practices and challenges. We would like to select a problem, idea, or challenges to work on as a team over the summer and create an active forum to share ideas and develop templates for products. The Data to Care Community of Practice series is a 4-webinar long series. Last month, South Carolina and Hawaii did an excellent job presenting case studies on implementation. Today's webinar will focus on policies and procedures for Data to Care implementation. So a third webinar in the series will focus on community engagement and necessary conversations, and that will be led by the state of Massachusetts. And our last webinar of the series will be operationalizing data and data systems, and we're going to hear practices from Washington State. We'll hear again from Colorado and Massachusetts. We're also requesting volunteers or other community of practice members who would like to share best practices or case studies on the webinars that will be conducted in May and in June. So for today's call, please press *7 to unmute your line if you have questions. We are conducting an interactive forum conversation, and we'll focus on discussions in the chat box. So please use the chat box. We would love to hear from you. Our presenters would love to have you ask them questions. We want to hear about what's really going on in your jurisdiction related to Data to Care. We also have polling questions throughout the call. Please participate in the polls. These questions will help guide future technical assistance related to the Data to Care initiative. So our learning goals today are, again, to hear about policies and procedures that will help navigate the Data to Care system. We're going to explore the legalities of data sharing and what policies, procedures, protocols were implemented in jurisdictions. And we're also going to hear about effective communications. So now I would like to turn the presentation over to our colleagues in Colorado.
And just a reminder, you can press *7 to unmute your line.
Can you hear me?
Yes.
Thank you. My name is Maria Chavez, and I'm the Statewide Linkage to Care Coordinator. I'm very happy to be part of this webinar to share Colorado's experience in developing the protocols and procedures for our Data to Care / Linkage to Care program. Next slide, please. Colorado wanted to know why too many people known to be HIV infected had not engaged in HIV care or had fallen out of care. In order to do that, we had to develop processes to determine who and where these clients were at the time. We needed to develop the process to engage and re-engage clients back into care. Next slide. Why did we implement Data to Care? We saw the need for finding people out of care, and we wanted to learn the reasons of why these clients were not engaging in care. What were the barriers keeping them from engaging or re-engaging back in care? In order to learn that, we wanted to be able to learn about that so we could eliminate those barriers. Was it transportation issues? Was there a substance abuse program? Maybe they did not have insurance. So we wanted to really find out the reasons of why people were not prioritizing their health before going into an infectious disease client. And at the same time, being able to identify the resources to eliminate those barriers to address this problem. Next slide. So how did we do it? Colorado Linkage to Care program started in mid of 2007. We used what we knew worked. DIS field investigations as a model for conducting our active linkage to care activities. We began working referrals from DIS. So every time the DIS would interview an individually, either newly diagnosed or who had relapsed an STI known to be HIV positive, they would look in the system and see whether or not they were engaged in care. And if they were not, at that moment, they would do an internal referral to our Linkage to Care program. We initiated a field record with the Linkage to Care disease codes and created dispositions specific to the Linkage to Care activities, all along with the creation of a Linkage to Care coordinator that would work these cases. Next slide.
So now we're going to ask a polling question. Based on Colorado's presentation, there are different models for loss to follow-up. In your jurisdiction, who's responsible for loss to care follow-up? Is it health department, disease intervention specialists, dedicated linkage to care staff, staff from Ryan White funded clinics, all of the above, or other? If it's additional staff, please use the chat box to note who is responsible for follow-up in your jurisdiction. So the results of the poll seem to allude to about a quarter of people are using their STD disease intervention specialists. About a quarter are using dedicated linkage to care staff. About 10% are using staff from Ryan White funded clinics. And quite a bit, almost half, are using staff from all of the above.
So how did we do it? Our surveillance colleagues had the CD4 viral load data that we needed. They could cross-tab the persons known to be HIV infected and identify those persons without a CD4 viral load. So beyond getting the DIS referrals internally, we started working with our colleagues in the surveillance team to develop reports along this. Once we created that list, we employed our disease intervention skills to locate and engage the client, doing a phone call, sending a letter, going in the field and really knocking on that person's door and seeing what was the reason keeping this person from engaging in care. We actively work with our clients through each of the steps of the engagement and care. And what was the sacrifice that we did? We reassigned an experienced DIS to this new Linkage to Care coordinator role. But the sacrifice was well worth it because we were getting great results. Next slide.
How do we measure our process? Good afternoon, I'm Kelly Voorhees and I work in the STI HIV surveillance program. We measure our success by helping more people move through the HIV continuum of care to achieve viral suppression. This measurement has been created in Colorado in many different ways using various denominators. So awareness of what denominator you are using is key to understanding the implications of your HIV Care Continuum measure. One way to create a cohort or denominator is to count all people living with HIV or AIDS in Colorado at the end of 2014 who had evidence of HIV care during the past 10 years. This is the cohort of people diagnosed with HIV. Linked to care is measured by those who had one HIV care visit in 2014. Retained in care is measured by those who had 2 or more care visits more than 90 days apart in 2014, or whose last care visit showed viral suppression. Achieved viral suppression is measured by those who had a suppressed viral load at their last measurement in 2014. This shows that their HIV treatment is successfully keeping the virus in check. Thus, in Colorado, this HIV Care Continuum measurement moves from 100% or 8,833 people diagnosed with HIV to 76% linked to care, to 70% retained in care, to 62% people who achieved viral suppression in 2014, and that's 5,481 people living with HIV or AIDS. In Colorado, we've seen this proportion of virally suppressed people living with HIV or AIDS increasing since 2010, when we began having more complete laboratory reporting of CD4s and viral loads to be able to document HIV care visits. A more immediate way to measure ongoing linkage to care efforts is to look at the proportion of people newly diagnosed with HIV each year who are linked to care within 90 days of diagnosis. In Colorado, we have seen this proportion increase from 87% in 2011 to 93% in 2014. Next slide.
Some of the things to consider. This is Rebecca, and the legalities of sharing data across programs and with external providers, those are things that you have to ask yourself what exists in your jurisdiction, what barriers might be there. Utilize your existing resources. Discuss with your CDC project officer what might be working with other jurisdictions. And your agency likely has a privacy officer, and those folks could help you identify some of those barriers as well. Is your program integrated? This hasn't been an issue so much for Colorado. We've been integrated from the beginning since HIV was first identified. For other jurisdictions, this could really be a challenge if your surveillance folks aren't permitted to talk with anyone about any of the information they have. What we found was really important as well as we began the linkage to care activities was building relationships, not just with external providers, certainly that was important, but building relationships internally, helping your colleagues, in our case, in the surveillance program that we worked very closely with, but helping them understand why we needed this data, what the purpose was of using this data. Also, building relationships externally with providers. When Maria was first accompanying clients to their appointments, providers were a little unclear, who is this person? They're from the state health department. They're helping the client fill out forms. The client wants them to be in the exam room for the first part of the examination. That's pretty different, and that doesn't happen in most medical settings. So helping the providers understand what her role was key. And as they began to understand really what her place was in this, it's been very positive and very supported. Next slide, please.
Can we ask a question? What were some of the most important considerations about maintaining relationships with providers? That seems to be a major challenge with some jurisdictions implementing new policies.
Well, for us, it was in part reaching out to the providers, helping them understand what Maria's role was. Part of what has been helpful is that providers are able to call Maria if they have concerns that someone is lost to follow-up. That person they're concerned may have fallen out of care. Perhaps they've sent letters, made phone calls. Not a lot of providers put a great deal of effort into that, but knowing that they could call Maria and that she would check to see if, in fact, we had evidence the person was in care someplace else, and if they weren't, that Maria would actually go out into the field, knock on their door, and find out what was happening for them and how we could help to facilitate their re-engagement in care. Maria, would you add anything else to what I just said?
And I think it was an evolving process, you know, as the provider would actually see me along with the client. They started seeing me kind of like a liaison of the client. It was kind of like coaching the client to ask the important questions that they would get during the actual appointment. It was giving the provider the proper information that they needed in order to provide the best care for this client as well. So it was a give and take. And I think that helped a lot, and it was a big attribute to building a very strong relationship with the providers around the Denver metro area.
Awesome. So you were adding value to their patients and adding value to their practice. That's fantastic.
So currently in progress, we have a data sharing task force, and that's made up of members of our STI HIV viral hepatitis branch and members of the community. For the majority of participants are members of the community. And folks participating have concern related to data sharing and what the department is considering when it comes to data sharing. But the real focus is how can we share data to the extent necessary to ensure the most seamless process for the client. And when it comes to being recertified for ADAP, how can we ensure that agencies are able to share information between each other, community-based organizations, aid service organizations, to facilitate accessing needed resources for the client. And so that group meets monthly, and we talk through these issues. We also clarified in our Board of Health rules, Colorado Revised Statute 25-4-1404, there's subparagraph B that has always allowed for the department to share information regarding HIV for the purposes of treatment, investigation, and prevention of HIV. And so we use the Board of Health rules to expand or to clarify our application of that. So in the example where a provider calls Maria, she is able to tell them, oh, this client is in care. She doesn't tell them where, because that's really not necessary for the provider to know, but to assure them that the client is in care someplace else. It's also provided the disease intervention specialist with the ability to share someone's serostatus with a provider so as to facilitate that person's ability to access care. Maria is able to share that as well. We also continually are, as we all are, in that education mode, educating providers, educating staff. HIV prevention is ever changing, as you all know. Increasingly in Colorado, we're talking about, yes, it's linkage to care, but we really focus on linkage to a medical home. So of course we want to get this newly identified or fallen out of care HIV positive person engaged into medical services, but we want to make sure that if they have diabetes, if they have congestive heart failure, what other health conditions they may have, we're not just plugging them into a specialty clinic that deals solely with their HIV care, but we actually are ensuring that they're getting linked into a medical home that can treat the whole person and can take into consideration the other health concerns that they have. And Kelly's going to talk a little bit about the Jsi Technical Assistance.
Next slide, please. Tools developed. We were fortunate to receive technical assistance from JSI through CDC to work on data to care issues in Colorado last year. One result was our Not in Care investigation protocol, which helped us to evaluate what we were doing around data to care process. And this review helped to bring all of our STI HIV programs to the table to consider the shared implications of data to care for Colorado, and it was really quite valuable. Surveillance worked with Linkage to Care to develop a quarterly Not in Care report. This was fine-tuned and changed over time, and the report continues to evolve to help prioritize our data to care efforts. Linkage to Care staff also developed Linkage to Care LTC referral tools for providers. And at first, we used only a DIS-only data to care model, but after receiving technical assistance from JSI, we broadened that model to become a collaborative cross-programmatic initiative within the branch. These tools include developing methods for DIS referrals to LTC staff to oversee every new positive in Colorado, as well as fine-tuning surveillance reports and evaluating our ongoing process using the HIV Care Continuum. Next slide, please.
So in terms of lessons learned, we really recognize our need to be able to shift and to change the way we're thinking about how we're doing what we're doing. And for some of us who have been around for a while, that's a real significant shift, because now you're sharing information with providers, with ASOs, AIDS service organizations, community-based organizations in ways that you haven't in the past. So it very much is a shift, but you have to think about what's best for the client and how does this best serve public health. We are working on a critical events program that will immediately address clients who are who have some very pressing life needs that create barriers to them either staying in care or getting engaged in care. For example, the homeless person with a meth addiction who would really like to get off of meth, would really like to have some stability in their life. We are developing with our partners in our care and treatment program this program to be able to support them in creating stability in their life and thereby helping to retain them in care. Our Linkage to Care program has actually been a model for what is our PrEP program. So really looking at how we have referred clients to our statewide Linkage to Care coordinator, and then she takes it from there to get them engaged. We're using that same model as the disease intervention specialists identify persons at highest risk for HIV acquisition. They then are following a similar sort of referral model to have our current interim PrEP coordinator then connect with those persons and be able to actively refer them to a provider who can prescribe them with PrEP. And with the changes brought about by the Affordable Care Act, we are increasingly looking at staff being able to enroll, and staff meaning Linkage to Care coordinator, our disease intervention specialist, being able to enroll clients directly into Medicaid. If someone actually doesn't qualify for Medicaid, we have colleagues within our care and treatment program who are healthcare access pros, and we can connect the client with these colleagues who can help them better navigate the insurance marketplace that we have here in Colorado. Next slide. And Tiffany, you were going to pull up.
Can you see the not in care protocol?
Yes.
Yes, this is the protocol that was developed with JSI, and they did a lot of work in helping us to focus on what are the steps, what do we need to do, and wrote much of this protocol. We, of course, now need to update it. A lot of things have happened since last summer, and one thing, which is what I was talking about before, in the continuum of care estimate that is in this protocol, it's based on a denominator of people who have evidence of care in the past 20 years, not the past 10 years. And that does change your end result and the proportion of people who are in viral suppression. So there's always going to be some updates. And now we'd like to bring people together to have all of the programs supply a little bit more information to this. Next slide.
The following is an example of our current external referral form to the Linkage to Care staff, and this was developed after the fact. We were receiving DIS referrals first, so we were targeting newly diagnosed. We were working with the not in care report from surveillance, and that helped us identify people who had been out of care for 12 months or later. But what was happening with those clients that were being engaged in an ID provider between the time of engagement and prior to that year without a CD4 viral load? So we developed this mechanism, like Rebecca said, so the providers would actually have a way to refer back to us after if this person was missing appointments, if they were falling through the cracks after they were engaged in care. This was an additional safety net that was created, so we would actually have a way to identify and prevent in an earlier stage that this person would drop out of care. We would have better locating information to go back, and we had already built a relationship with them. So this time around, when Maria would call on the phone, I would call like a follow-up to say, how are you doing? How were your doctor's visits? Are you having any side effects to your medication? Is there anything that I can do to help you and assist you? So we had already built a rapport with the client, but they had fallen through the cracks, and it was a way for us to be in the picture again to ensure that we were available to them to retain them or re-engage them back into their provider. Next slide.
Our process map really looks at sort of what was going on before and what's going on after. Our Board of Health rules really didn't have clear information regarding the sharing that we could do of the public health information that's held here at the health department. Our Linkage to Care specialist was still working off of the internal referrals from the disease intervention specialist, and our surveillance reports were much more internally used and not shared so much externally. So really our after, we're looking at the clarification of our Board of Health rule, which, as I said, helps to expand the way in which we can share information for the benefit of ensuring that a client is getting care. We have a statewide Linkage to Care coordinator. There are lots of different agencies that are engaging in different levels of Linkage to Care activities. By making a statewide Linkage to Care coordinator here at the State Health Department, Maria has been able to reach out to the other agencies and work to coordinate efforts so that there's not a duplication of services with external providers that are out there, community-based organizations, aid service organizations that are working to link clients into care. And our surveillance reports now are shared with our community planning group and with our data sharing task force. And we really focus on the continuum of care data and being able to show how that has changed over time, how it's actually improved over time with the combined efforts of working to get people linked into care, to really reach out to those folks who have fallen out of care and getting them re-engaged. Next slide, please.
So this slide shows a process map for the Linkage to Care activities. through our work with the JSI, our internal communication was improved. We wanted it to be under the same understanding. How were the cases being worked, and what tools were we using in order for us to understand that better, and also what were the outcomes, and how can we close the loop back. So the first link says the database is used to update our care status. We were doing a pre-case analysis to determine if once this client reached to me as somebody that was out of care, I would do this pre-case analysis to determine, is this person really in Colorado, and is this person truly out of care? So we would actually do all of the searches necessary to determine that. We currently use a database search that is called the Largest Law Enforcement, TLO, or LexisNexis, some people know it. So that gives us the opportunity to really look for the most up-to-date locating information for the client. If it is determined this client is in Colorado, we then look at CD4 viral load. If we may actually look at the history and see who the provider was. So we contact the provider and say, is this person truly out of care? We can look into our ADAP system to determine whether or not is this person maybe not having CD4 viral load labs, but they're taking their medication every month. So once we do that pre-case analysis and really determine that this person is a Colorado resident and is truly out of care, at that moment that field record is assigned to our Linkage to care staff and is being worked under the field investigation, which entails the phone calls, the field visits, the letters, looking at different social network sites, for example, Facebook. Facebook has great information. What do they look like? So if I go to the field visit and I knock behind the door, I know that when that person comes and answers the door is the person that I'm looking to talk to. And it has great resources. And once we determined and really close our investigation, we are able to determine, whether or not this person might have left the state. Maybe they were not locatable. Maybe they were locatable and they accepted our services. So we're able to track all of our activities, and in a way, we report back to our surveillance team so that person in the next quarterly report is not shown as somebody that is out of care, because that's not the reality. Next slide.
Hi everyone, this is Michelle. Thank you for sharing the different search engines you use to locate your information. What other tools does your state use to update surveillance location information? In Hawaii, I know that we also use LexisNexis. We can utilize our STD database. I know we have access to WIC services information. What other databases are people using?
You're on mute, so please chat your responses to our questions. We would love to document. Colorado's doing some fantastic, extensive work on non-public health related databases. So we really want to try and see who else is doing some innovative practices. As we transition now to Debbie Wendell, again, please chat your responses and your thoughts about the content thus far. Debbie, now we're going to hear from you. Star 7, unmute your phone.
Hi, everyone. Can you hear me?
Yes.
Okay, great. I'm going to talk a little bit about our LA Linkage and Re-engagement to Care project, which in many ways is similar to the Colorado project. We're doing linkage of care to newly diagnosed folks, re-engagement, and patient navigation. And this project is implemented in the 3 parts of the state that have the highest HIV prevalence. So we're focusing on New Orleans, Baton Rouge, and Shreveport. We're creating electronic line lists on a weekly basis using an automated series of SAS programs. And so we have electronic line lists that our interventionists use to find the new cases and to contact persons. The one key difference with our project compared to the Colorado project is we made the decision early on not to use DIS and instead are using our specially hired linkage care coordinators who are Louisiana STD HIV program staff. And we made that decision for a couple reasons. First of all, in Louisiana, we continue to have a huge syphilis epidemic, and we're also seeing increases in new HIV diagnoses, especially in New Orleans and Baton Rouge and Shreveport, actually. And so our DIS are really overwhelmed with just their regular syphilis and HIV caseload, so we didn't feel like they could also devote time to linkage to care activities. We also wanted to have staff who were located in our office that had access to EHARs, LexisNexis, other surveillance databases so that they could get information in real time. So our 5 linkage to care coordinators who are either social workers or nurses are working out really well, although in the future we may decide to also train some DIS to take on that role. I also just wanted to highlight that in Louisiana, I mentioned we do linkage to care with persons who are newly diagnosed and persons who are living with HIV who have fallen out of care or have never been in care. However, we're also doing these activities with a third group, which you can see on your screen, and this is people living with HIV who have high viral loads. So they may not be receiving ARTs, they may be exhibiting treatment failures, there may be adherence issues, and this group has been a great group to work with. It has also posed some challenges. So one of the things that we have established is an eligibility criteria and kind of an ordering of these cases. So, so you can see our group 1, our high priority group, are folks who have a first viral load of over 100,000 and a second viral load which is 3-fold or greater increase. So we're looking at folks who've had more than one viral load. And then, for example, our second group is folks with a viral load greater than 100,000 and a second viral load where there's no significant decrease. And you can see, again, there's a third group, fourth group, fifth group, et cetera. Early on, we were also including people who may have had an initial viral load that was undetectable, but a second viral load that increased. We eliminated that group mostly because the providers felt like some of their clients may have blips in viral load, they're in regular care, they're adherent, and that isn't a group that we needed to work with. So as we've been going along, we've been revising some of our eligibility criteria. And you'll also notice that we're only following up on folks who we know have been in the state in the last 3 years. And so that's different than some of the other state protocols. And the reason we did that is just mostly because we don't have enough staff to contact everyone, and those folks have a greater likelihood of actually still being in Louisiana. I think if our linkage to care coordinators ever run out of work and have some free time, which seems doubtful, we might expand that eligibility criteria to either 4 years or 5 years. So that's the Louisiana project in a very brief summary. And I'd be happy to take any questions.
Hi, Debbie. This is Tiffany. And this is for the entire group in the community. You indicated that you run your not in care list on a weekly basis. Can you talk about how that decision was made, and then maybe other jurisdictions in the chat box who are also running their list can talk about how often they run their list as well?
Okay, I think we chose we have an automated process, and it's linked to EHARS, and so we wanted to update the list fairly frequently, because if someone, if we get indication that someone has died, or if someone all of a sudden gets into care, or if someone moves out of state, we're able to quickly update the list. I think if we were doing a more manual process and not an automated process, we probably wouldn't update the list that frequently.
Okay, thanks.
That's we picked weekly.
Great. Now we're ready for our next polling question. In your jurisdiction, has your jurisdiction considered changing how it prioritizes cases for an investigation to accommodate data-to-care activities? Lots of yeses. So if you're responding yes, we would love to hear, how you changed your priorities in the chat box. Was it that you stopped investigating a specific STD? Did you reprioritize your reactor grid? Did you integrate HIV and STD partner services? If you could respond in the chat box, that would be fantastic. Now we're going to transition just back to Colorado just to talk briefly about additional tools that are needed.
So this is Rebecca, and really that legal ability to share your surveillance data with prevention programs.
I'm going to start a little bit.
And Kelly's going to talk more about the data system.
Say one thing about tools needed, and this is Kelly again. We needed increased legal ability to share our surveillance data. This was a radical concept for many in surveillance. We had to learn how to create MOUs and update our security policies and training standards, and increase our comfort level to share data that had never been shared before. We also had to improve data systems that were not designed to collect critical data elements, such as current address and complete reports of CD4 and viral load values. This helped us to create usable not-in-care reports. We were extremely fortunate to have skilled staff with a wealth of experience developing measurements for the original Colorado HIV Care Cascade. Staff had the experience to understand subtle differences in EHARS data and were able to define valid denominator populations. Staff had data skills to accurately merge EHARS case records and CD4 viral load warehouse data systematically and repeatedly over time to be able to use all available information for data-to-care measures. Staff also had SAS programming skills to write and help interpret quarterly not-in-care data reports, and this truly provided consistency from report to report.
So here are my bullets. So we needed skilled staff who were able to have those conversations with clients, and we chose an experienced DIS because we knew we needed the investigation skills. We needed someone who knew how to find people, even if they weren't really interested in being found. And so some of the skills really necessary is someone who is engaging, a good listener. Really, the characteristics that you look for in a good disease intervention specialist are really what we have found to be exceptionally successful in doing linkage to care work. They're same sort of knowing when to ask the right question, what questions to ask, and being willing to ask the tough questions about income and life situation. The ability to identify gaps in the system and those barriers for clients so that we can report back to the larger branch and be able to identify ways that we might be able to help address those. Part of that resulted in the development of our critical events project, and to develop a network of resources Oftentimes it's the simplest thing, like having a stroller for the baby that really weighs too much for mom to carry to the bus stop, on the bus, and then through the hospital to get to her care appointment. And knowing where you can get those sorts of resources on behalf of a client. And that's just a small example of having a good network of resources and knowing how best to work those to the benefit of the client.
Thank you for sharing. Now we're going to transition to New York State. That resource network sounds like a fantastic idea. We would love to hear from jurisdictions who have a similar resource inventory or network of resources that are available for clients. Now we're going to hear from Megan Johnson about New York State's development of policies and procedures.
Great. So can you go ahead? Can you hear me?
Yes.
Okay, great. So we're going to be a little formal here. I'm just going to prompt Erin when to transition my slides because there's some animations for folks. So again, thank you for having me. I'm Megan Johnson. I'm the Prevention Services Coordinator for the New York State Department of Health's AIDS Institute Division of Prevention Services. We can go ahead to the next slide. So I just wanted to show today's objectives for the presentation are I wanted to go over kind of like who the major players are for data to care in New York State, provide a little bit of a history and context to what we have going on, talk about our approach to developing protocols, talk about the job aids that we've created along the way, challenges that we've run into, and the special training that we have developed for our linkage specialists, or expanded partner services advocates as we call them. They're trained DIS. So we'll get into that. Next slide. So briefly, I just want to show that the AIDS Institute is a pretty large agency within the New York State Department of Health, and our data to care work is kind of nestled between the Division of Epidemiology, Evaluation, and Research and the division that I sit in, which is of Prevention Services for HIV, STD, and Hepatitis C. And you can see the main players of the bureaus underneath HIV Epi, STD Prevention and Epi, and field services and community-based services. Next slide. So in New York State, we have three data to care programs. The primary one we're going to be talking about today is the Expanded Partner Services initiative. It is a health department model where we're using the surveillance data to find people who we are presuming to be out of care. Our definition is we look for folks who have no CD4 viral load within our tracking system for 13 to 24 months. And we did have to cut that off at 24 months just because of the magnitude of people that we have in New York State that are HIV positive and out of care. If we, used a larger time frame than that, it wasn't, we didn't have enough staffing to cover the number of people we had out of state or in New York State. A second data to care program that we have is the High Impact Care and Prevention Project, which is actually funded from the national level by CDC and HRSA through the Partnerships for Care funding stream. It's a 3-year demonstration project, and this is a combination model where we're using both health department surveillance data and healthcare provider data to find those folks who may be out of care. We have 4 definitions that we're running with that initiative. We're looking at people who are out of care for no CD4 or viral load, people who were diagnosed and never linked to care, and then we're looking from the health center perspective of 6 health centers who are participating in this demonstration project. We're looking at their medical records and seeing who hasn't come in for an HIV-related medical visit for 9 months, and then those folks who were diagnosed at that health center and never linked to care. And our third data to care program is what we call Expanded Partner Services in the Department of Corrections. And this, again, is a health department model. However, it is a unique collaboration between the Department of Health and our Department of Corrections. So those are just state correctional facilities. We're not talking about county jails here. So we're using the entire census of inmates, both male and female, in New York State and the Department of Corrections. and we're cross-referencing that with our HIV surveillance data to do a match. And we have, two definitions that we're looking at, one for folks that are in custody and one for folks that are out of custody. In New York State, we have about 53,000 inmates that are held within 54 state facilities, and we presume that there's 2.4 to 3.7% of those folks are HIV positive. Half of those are known to docs, and the other half are not. And that's largely, we feel it's largely due to their resistance to disclose because of stigma and poor perceptions of the medical care services in docs. So going forward for the rest of the presentation, I'm going to be talking about the expanded partner services model, which is the one to the left. Go ahead, next slide. Oh, one more. There we go. So this is, I just wanted to give a snapshot of the timeline for data to care in New York State. So as you can see, it started as a concept paper in 2012 and all the way to, today where we have 3 initiatives going and it's statewide across New York State. So if you could just push the next button. For the animation to come up. We have anything that's in blue flagged is EXPS. Next button. Yellow is that expanded partner services in docs. And next. Green is going to be something that's related to HICAP or that partnerships for care. So go ahead and next button. So when we initially started and we were starting to think about what data to care would look like in New York State, it took us about 7 months to come up with a solid protocol document, and it wasn't necessarily just like putting pen to paper and writing that. It was really the modifications of our systems and enhancements for looking in our surveillance system and then triggering case assignments for our disease investigators or linkage specialists. So go ahead, next button. So if you see there, we had about a month without working with our protocols, but as soon as we had those case assignments that went live in September of 2013, we realized that we needed to make some serious modifications to our protocols and make some enhancements to the systems, the systems that we had for data entry and evaluation. So next button. So we did release the statewide, an updated protocol in April before we went statewide, before we were a pilot in 4 counties. And if, history repeats itself, we think that we're going to continue and always have to update our protocols as we're learning more and we have more unique cases coming through. So next slide. And if you can see there, sorry, it took us about 2 years to modify and enhance our protocols. I'll get back to that. So when we were developing our protocols, we used, we reached out to both internal players and external players within New York State. We had an internal work group with our surveillance team and our prevention team. We needed to figure out what systems we had in place and how we could, enhance them to get this work done. We had to look at our workforce team across the AIDS Institute to see, who we could pull in and who was best fit to, from computer programmers all the way up to program coordination and steering committee members. We looked to our Bureau of HIV/STD Field Services for that staff experience and technical assistance. And we had to reach out to our Office of Medical Director to help us come up with just what would be a sound out-of-care definition for New York State, using, clinical guidelines. And we wanted to really hash out a step-by-step process for working with medical providers because, again, we are using linkage specialists or especially trained DIS. And the first step in our protocols is for them to reach out to medical providers. So we really wanted to solidify that and approach the medical community in the best way. External players, we reached out to our colleagues at the New York City Department of Health, first and foremost, to get their experience. They have been running a similar model, for a few years prior to us starting. And then the 4 pilot counties who we started with in 2013, we really worked with their health commissioners, their directors of their STD clinics, their program directors to uniquely define how our Data to Care initiative would look in each of those counties. So next slide. We brought the community in at several levels, at several points in time. We really consider expanded partner services a cross-sector model between local and state health departments, community-based organizations, and health centers and individual medical providers. We held focus groups in pilot counties in early 2013. We presented both in New York State and New York City to medical providers. We have a New York, like a Links collaborative that meets regionally. We sent out Dear Provider letters on 2 occasions to medical providers, nurse practitioners, midwives, emergency room doctors, and other local health departments, letting them know about this initiative and handing out a program summary document. And you can see kind of screenshots of both of those here. We worked with our community-based organizations that are funded through the Division of Prevention and our healthcare division, and we shifted some of our funding at the state level to fund these navigation and linkage services to help with some of the barriers that we were seeing, like transportation, child care, and so we could pull our CBOs in to help work with some of those barriers. We also we funded the county health departments to hold the main part of the work. They were the disease investigators, who were county health department staff, and so with the county we had work plans and contracts, and within those we required them to establish collaboration agreements or MOUs with both medical providers and CBOs in their area. Next slide. So what you see on the left when we started our protocols is they were very legal. This is our first version back in 2013, and it was very much written like a legal document, because what we had to do was really examine New York State public health law and see where this all fit, and it had to go through our legal department and straight up the chain through our commissioner and our overseeing health authority in New York State. So if you go to, or the next button, please. So then we revised our protocols to be way more user-friendly for the linkage specialists. And Erin, you can just click through a couple of times. There's several screenshots here. Our protocols now outline the roles and responsibilities of folks involved, case investigation and outreach protocols, prioritization of cases within the cases that get assigned to them, how they should collect data and enter it into our tracking system. We have some pieces on troubleshooting cases and communication plans on who they should reach out to and talk to at the New York State Department of Health when they come into those into problems. Next slide. So same here, Erin, there's several pictures that will all come up. So with we created several job aids for our staff. We have an extensive training, which I'll talk about. We have a protocol document. We created a definitions document because we found that with DIS, they are now working more with medical providers, and they weren't understanding all the acronyms that were necessarily being used by some of the providers. So we made a comprehensive tool for them. We have a list of all of the disease investigators across the state who are doing this work, and it's roughly 25 to 30 individuals, and we really want to foster them reaching out to each other across regions and counties to best work with for a patient-centered approach, because we do see patients crossing borders and moving within and out of jurisdictions at the local level. This is a snapshot here of the work plan that with the counties that shows it's very prescriptive with performance measures and objectives. Next button. We have quality assurance reports that we run in real time. We do them monthly. We may transition to bi-monthly in the future, but right now we really like to get a handle on that. I have a data coordinator who runs those for me, and then they're sent to me and I get them out to the partner services staff at the local or regional level, so they're in real time and we can troubleshoot cases. The next screenshot there is a tool that we have. All of our work is grounded in the trans-theoretical model of behavior change. And so this gives some strategies and interventions that we found useful in gauging patients' readiness to relink to care. And so there's some tool or key strategies for our staff there. Next. This last screenshot is probably the most helpful for our staff. It's a one-page case investigation form that they can take out into the field with them, and it's completely de-identified, so it doesn't reference HIV on the field. And when we were working through this with our partner services staff, developing our protocols, they said short and sweet. If we can just have a one-page document with all the variables. So we worked pretty hard, and it mirrors the tracking system that they have to electronically enter the data in on their end. So next slide. And I promise I'm going to move faster. So we do have a 3-day training, comprehensive training that we've created in-house for our linkage specialists, because we found that there wasn't, a national training that was meeting our needs, and the Passport to Partner Services trainings really didn't cover, looking at the care continuum and meeting clients where they were at the various points in that continuum. So the training really talks about the key goals and objectives and data collection. We brought in Ciccatelli Associates to do a 2-day motivational interviewing training with a trans-theoretical model of behavior change. And we made those, the screenshot in the middle, the purple screenshot, is a workbook where I worked with Ciccatelli to come up with solid examples of what it looks like to work with patients in out of care. And then the screenshot all the way to the right, there is our competencies that we have developed. I think it's 10 there, 10 core competencies that we would like to see for our linkage specialists.
Hey, Megan.
Yeah.
This is Michelle from Hawaii. I was wondering, is this training available for other jurisdictions, or is it available online? Because it sounds like a great tool.
That's a great question. It's not available, online. It's something that primarily myself and another woman created for New York State, and we worked with Ciccatelli to kind of enhance their component of it. But it really is a training that, myself created the 2013 version that we did, the initial version, and then we just recently redid it in February. I've worked with a couple of jurisdictions that have reached out to me personally to help do theirs, Massachusetts being one, and California. So it's not available yet, but...
I'm happy to hear that, and that you've been working to share it with other jurisdictions. Thank you.
Yep. Okay, so next slide. Where am I? So challenges in this work, we've found that, with any, program, is monitoring data and quality. And then also using the quality and processing of surveillance data for out-of-care work. And I believe it was Colorado who spoke a little bit earlier, is when surveillance, this is a new intervention, let's say, and so surveillance data originally wasn't thought to be used in such a way, and we've been working with what we can to get this initiative rolling in New York State. And it posed a little bit of some challenges at the beginning, but we think we've got it down now. Again, coordination of the initiative. At the beginning, when we looked at all of our staff across the AIDS Institute, we really had to bring in lots of people to sit at the table and make this work, at a central location, and then also at the regional level. Our linkage specialists we initially used, trained and what we were calling, seasoned staff. But now, since it's statewide, we have some newbies who are brand new to disease investigation. So that poses a challenge as well. And we also, because we're working with state and local staff, access to up-to-date protocols and all those job aids, because this work is constantly changing and we're reevaluating and moving, we didn't have a place because of firewalls and servers to host all the data. So we have an internal, external SharePoint site that is available for our staff across the 2 jurisdictions, and they can access this, and I update it with protocols and recent published articles. And so it's just a way to kind of bring us together as a community working on this work. So next slide. We have had to make some known modifications. I was saying it took about 2.5 years to modify those protocols and to roll something out. We changed the assignment basis from last known provider to what we thought was last known residence when we assigned cases out. And this significantly reduced the number of out-of-jurisdiction cases. And what we're seeing now is it's less cases that we're transferring from one county to another or one regional office to another. We changed what we call as the drop date, the assignment out. We assign cases out monthly, and we were assigning them out at the beginning of the month, but that wasn't necessarily in queue with our when our CD4 and viral loads were coming into our surveillance unit. And so we decided to change that up and start rolling them out in the middle of the month, and that was reduced the number of cases that we were pulling back because we had received a CD4 or viral load on those individuals. For folks where we found that they were actually current to care, but our surveillance system, they were showing if they were out of care because we had no CD4 or viral load, we asked the linkage specialist to contact, the last known provider and see if they could get from their EMRs the accession numbers or the draw date so that we could see if that record was within our tracking system so that we could match that lab to the actual patient. So it really is, this work is also benefiting surveillance and helping to, connect people and clean up records. And we also, again, use LexisNexis to help locate hard to find individuals. Next slide. So what we've learned mostly about this work is that it's much different from regular partner services, and where we have strict time frames of 14 days, 21 days to get a case assignment and to interview that person and get them treated for their STD or into care for a newly diagnosed HIV positive. And with this work, we really stress to our linkage specialists that we want to meet the patients where they're at and help reduce whatever barriers are in front of them to accessing medical care. So we're not only just linking them one time, but that linkage will hopefully help retain them if we are successful at reducing those behaviors or barriers. So that goes back to the cross-sector approach. We pull in the community-based organizations that are funded across the state when we need to, as well as the medical providers, and then us at the local and state level. Next slide. Oh, that's it. So there's my information. I'm the coordinator. Brittany Johnson, who is not related to me, she's the data coordinator who is heavily involved in this initiative. And at this point, I'm unable to share the materials that you saw screenshots on at this point, but maybe in the future. Great. Thanks, Erin.
So, Erin, do you want to unmute the lines? I know we're over. Do you want to unmute the lines and take a couple of questions? If people have burning questions for the presenters, we can take a couple of minutes now. Thank you for staying on, and thank you for your patience. We're really excited that everyone stayed on the call after time.
Yeah, I think if anyone has questions they want to ask over the phone, they can just press *7 and unmute their line individually so we don't have any background noise. So you can go ahead and press *7 if we have any questions over the phone.
Hi, Erin. This is Michelle, and I don't know if you guys have been paying attention to the chat box during the presentation, but I don't think participants could see responses from other participants. I got a couple of comments about that, so I was wondering if, some of those questions, and we got some wonderful answers, if those would be able to be shared afterwards.
This is Erin. We'd be happy to send out the transcript after the webinar so that everyone who participated can see the answers that others were submitting during the presentation.
Perfect, thank you. I'll just ask a question to the group, and I'm going to kind of go based on what the last thing Megan was presenting about training. What are some training needs that you have in your jurisdiction? It could be for your linkage staff, your DIS, surveillance. I know something here in Hawaii that we would probably benefit from is a training for our DIS staff, who are the ones that will be doing the actual re-engagement and care work. Do other jurisdictions have training needs?
Just a reminder, you can press *7 to unmute your line if you'd like to answer.
Okay, if you guys, any other questions? If no one wants to discuss training, we can do it in the chat box. Or are there any other questions that the group has?
Okay, well, thank you again for participating in our webinar. We just want to remind everyone that the next webinar is Thursday, May 14th, and Massachusetts will be talking about community engagement. If you have questions that you didn't want to ask during the webinar, or you are interested in sharing your experiences either on community engagement or database development or data management, please email Erin, and her email address is located below. So thank you again for your time. Alabama attempted. Okay. So thank you again for participating in the webinar. We look forward to your continued participation and engagement in data to care activities. Erin, did you have anything to add?
No, I'd just like to thank you, Tiffany and Michelle, for co-facilitating, and then to all of our presenters who shared their work with us today. I also just want to quickly add that there will be a survey that pops up right after the webinar ends, so if you could please take the time to fill that out and provide your feedback, we would very much appreciate it.